Hello, I'm Donal McCauley, and welcome to this Medics Voices conversation where we talk to the key opinion leaders in health and medicine around the world. Today we're in Sweden and I'm talking to Minna Johansson. Minna is a GP, she works in the Cochrane Centre in the university, but she leads this new global centre of sustainable healthcare. But before we get on to that, let's take it back to the very beginning. Growing up in Sweden, what interested you in medicine?
The fact is that I had a friend who was moving up to the far north of Sweden, and I wanted to join her. So I basically applied to get into the university far north of Sweden, and I started med school there. I got in and I started, and I absolutely loved it. So I was spellbound, you say, from the beginning. I thought it was amazing.
But let's take it back before that, because you did other things. You worked as a care assistant.
Yes, I did. Yeah, I worked for a couple of years as a care assistant at nursing homes, and I really learned a lot from that, both in terms of caring for people who are very vulnerable and what that means, and also the situation for the care workers, which was not very good in many cases. So yeah, maybe that did inspire me a little bit to wanting to start medicine. Yeah.
So what were you doing at that time? Were you at school or was this your occupation?
Yeah, so I had like after I finished gymnasium, we call it in Sweden, so the kind of mandatory school, I worked for about 3 years as a nurse assistant or as a care assistant. Yeah. So I didn't study at the same time. I just worked with that. I think it's good. I mean, whatever occupation you choose, if you choose to go to the university later in life and study, then you will end up, many of us will end up in quite privileged positions. And I think it's a good thing to have gotten some experience from the world before you start the university. So I that was very valuable to me, and I still think about it quite often. The people living at these nursing homes, what I learned from them, and also my colleagues who I worked with. Yeah.
So you moved to university in the far north of Sweden. Tell us a bit about that.
Yeah, I had a lot of fun there. I met my future husband in the and I it was a very good environment to study in, very low hierarchy. Like it's a quite new university, so not so much sort of tradition that could like I don't know. It was quite what do you say? Progressive, I think, in what was taught and how we learned to understand medicine. So I'm very grateful for studying medicine there. It was quite cold and quite dark, but as a Swede, I like that. So it was good, and I met a lot of friends also. Many people moved there, so not many people lived there. So most people in my class moved from all over Sweden to. So it was very easy to get to learn to know more new friends.
Well, were you as dynamic at university as you have been afterwards? Were you a keen student?
Yeah, I was very enthusiastic and motivated to learn, and not only the curricula, I think, but more like what does this actually mean? What's the point of all this? Yeah.
So at that time, what was your exposure to family medicine?
First in Sweden, after we finish med school, we go to different specialities for about 1.5 to 2 years. So everyone has to do that in an internship. And I really liked every place I went to. I really liked it. So I thought like I wanted to be first an orthopedic surgeon, and then like a cardiologist, and then an ER doctor. But then when I came to family medicine, I was like, okay, now it all falls into place. And I think this really I really love to have this, to not have to fragmentize everything, but to actually be able to understand what's the problem here. Like what's to zoom out, be allowed to zoom out and understand what's the problematic situation that this person is in, and how can I help in the best way possible to solve that, to try to help solve that situation. And also, of course, the continuity of the relationships. I mean, it's just I think I've learned. I mentor GP residents in my work at the healthcare center, and one of them said after being a GP resident for 1 year, he said something like, I feel like I have lived 100 years from just this experience. I mean, you meet people in extremely vulnerable situations and they just share with you and you follow them through these journeys of sometimes extremely difficult experiences. And I think that's just such an honor and a gift and a privilege to be in that situation and have that and have people in vulnerable situations just be able to be a part of their journey. So, I mean, I was just after a few months in the family medicine center, I was stuck. I could not even imagine another place to work.
So for those of us who aren't familiar with the Swedish system, just recap on the process from medical school to becoming a GP.
Yeah, so first you go to medical school for 5.5 years, and then you have this internship for about 1.5, 2 years, where you rotate through different specialties, and you end that rotation with family medicine for 6 months. And then you go, if you want to be a GP, you go to specialty training, and that's 5 years of full time. So yeah, compared to many other countries, I think it's perhaps a little bit more, you can't call yourself a GP after this internship. You have to go this specialty training for 5 years to become a GP. And during those 5 years, you work at the healthcare center, and you must be responsible for nursing homes or for children checks. I don't know what it's called. Like you check children yeah. And then also you have to do some rotations. You have to work a little bit in psychiatry and in medicine, in the internal medicine wards, etc. Yeah.
Well, was this an academic center? Were you interested in research and academia at this stage?
No, I live in the countryside. I live in a small town on the west coast of Sweden, so there's not much research going on around me. When I started as a GP, I felt like this massive frustration about that all the guidelines and all the quality metrics and all these incentives pushed me towards caring for people with low risk and low benefit from the care I provided. And at the same time, I did not have time to care for the people with much higher risk and much higher benefit from the care that I could give. And I mean, that was a constant frustration for me every day when I came home from clinical practice. I was like complaining to my husband about the misery and it made me very frustrated and angry. And so the reason I started with research was this kind of anger and frustration that I wanted to change this situation, to have a better prioritization, a more human, more efficient, and more sustainable prioritization of my clinical work. And then I got in contact with, I was very fortunate to get in contact with so many brilliant, world-leading researchers around the world who have supported me and helped me and developed different ideas with me. So I mean, it's been a very, very fortunate and privileged research journey in that sense.
Well, let's talk about that journey, because you're in a small practice in the coastal area and you did a PhD. A fascinating topic, fascinating title. Tell us about that.
Yeah, I did a PhD on evaluation of screening programs, so benefits and harms of screening. And it contained studies on screening for malignant melanoma and screening for abdominal aortic aneurysm. Yeah, and it was very controversial. It got a lot of debate in Sweden, which was not always positive. I got like anonymous hate mails with very sexist content, etc. So it was a bit hard in that sense. But basically, the studies was evaluating whether the current screening program for abdominal aortic aneurysm, how large the benefit was compared to the trials that were done previously, and also how much overdiagnosis and overtreatment that occurred due to the screening program. Yeah.
Well, you described it as the streetlight effect. What is that?
So I think that a lot of the stuff that we do in medicine, we don't understand how much our own perspective will affect how we understand interventions and what we decide to do. So the point with the streetlight effect was that we tend to, in screening as an example, or in prevention medicine in general, we tend to focus our gaze towards the outcomes and the interventions, the research questions and the interventions and outcomes that are very individualistic and biomedical in its sense. But then we miss everything that is outside of the streetlight, which, for example, if we take screening for lung cancer, it's estimated to save about 12,000 of 160 deaths from lung cancer every year in the US, and that might very well make lung cancer screening worth the effort. But in the same country, interventions to decrease smoking is estimated to save more than 160,000 deaths. So more than 10 times as many deaths. It's much cheaper and has less potential for harm for the individual. Of course, lung cancer screening will lead to overdiagnosis, unnecessary biopsies from the lungs, etc., with sometimes serious side effects. So I think we are very focused on understanding the problem of preventing disease and disease in terms of an individualistic lens. And then we miss to zoom out and understand it in a more wider landscape. Yeah.
So you've done your PhD. What happens next?
Yeah, I was I was very tired of research and I took a break and just worked clinically for a while. But then I was kind of recruited for a new Cochrane Center just started in Sweden, and the director there, Matteo Bruschettini, is a very kind and generous professor, and he sort of convinced me to start working for the center. So I did, and then I was teaching and supervising master students, etc. And then after a while, I couldn't stop myself. It was just too interesting. So I just started with research projects again. So now I have started several research projects, and the focus of them are more. I left screening behind because it was such an inflammatory topic. So now I'm more focused on sustainability of healthcare. And I'm very interested in how we prioritize our time as clinicians. That's my specific interest, but it's also much wider than that. I'm also interested in how we prioritize between individualistic oriented prevention efforts within healthcare versus more structural interventions targeting populations. From a more policy perspective. Yeah. So now I have 2 PhD students that I'm a main supervisor of, and a few that I'm co-supervising. And so yeah.
So tell me then about the Global Centre for Sustainable Healthcare.
So I felt that I felt that one of the major problems within medicine, all the way from primary research to evidence synthesis to guidelines and policy decisions, was permeated by an almost extreme inability to prioritize. We seem to understand professional healthcare as an infinite resource, but it's not. It's a finite resource. And we need to, the consequence of that we don't prioritize is that healthcare becomes inefficient and unequal. And I think that problem needs to be handled in a more zoomed out perspective. We need to work not in silos, understanding one issue at the time from a sustainability perspective, but more this wider lens to understanding medicine through a sustainability perspective. And that's what we want to do with this Global Center for Sustainable Healthcare. So it's a group of many people from across the world, from many different countries, working on these issues from different perspectives. So understanding what we do in medicine through a lens of sustainability. And that's sustainability for patients, for clinicians, for health systems, for societies and communities, economies, and the planet. So we are basically like a group of people getting together on this platform, the Global Center for Sustainable Healthcare, to try to figure out these issues together in many different projects. And the work is very permeated by this idea that it's not for our own academic benefit. It's more, this work is about generosity, sharing ideas, and trying to advance medicine and the way we do medicine for better benefits to the patients and also to our communities.
Through your work, you've explored a number of absolutely fascinating concepts. Talk to me about the time needed to treat.
Yeah, so the background there is that there are lots of studies that have shown that it's impossible for clinicians to follow guidelines. For example, there's one US study showing that GPs would have to work 27 hours every day to follow the guidelines that apply to our patients. There's one study from Norway showing that we would need more GPs than are available today to only follow the hypertension guidelines. So we would have to stop everything else and just do hypertension. And there's one study from the UK, which I was involved in, that showed that we need more doctors of all specialities and 5 times as many nurses as currently working in the NHS to only follow the guidelines on lifestyle interventions. So obviously there's a massive mismatch between what is recommended and expected of us and the time that we have to care. And the consequence of not doing this prioritization of what we are supposed to do is that we don't spend our time on the patients with the greatest care needs, and we don't spend our time on the interventions with the greatest benefit. So I was super frustrated by this. And I remember being at my healthcare center, and there was this new guideline coming with no consideration of the opportunity costs that would mean. There was no, it recommended a lot, but there was no considerations of all the patients that I serve that will not be able to get care if I implement this guideline. So I went on my bike home and was very angry. And then on the evening, I wrote this draft for this paper about time needed to treat. And then I contacted Professor Victor Montori from Mayo Clinic, who is just a brilliant and super generous person that I've worked a lot with, and I'm so fortunate to do that. And also Professor Gordon Guyat from McMaster University, who is one of the founders of evidence-based medicine. And we worked out this concept. So the concept of time needed to treat is basically a very simple model that aims to help guideline panels understand clinician time as a finite resource that need to be prioritized. So you estimate if you would follow this, if we want to recommend something, if clinicians actually would follow this recommendation, what proportion of the total time that they have available for patient care would be spent on this intervention. And in many cases, you end up with very large numbers, which would then help. The idea is that the guideline panel will then take a step back and consider, is this reasonable? And what in relation to the benefits of this intervention, and is there what care should we recommend the clinicians to stop doing to make space for this new intervention? Yeah.
And this brings us on very nicely to a paper you wrote recently that suggests that lifestyle guidelines don't actually work.
I mean, I think one of the biggest problems related to this is when a patient comes to us with a problem that they want our help with, then it makes sense to discuss all kinds of interventions, even the one with maybe low evidence to support it or a small chance of benefit. But in the last few decades, the prevention efforts within medicine has expanded almost exponentially. So we have gone from trying to prevent disease in a small proportion of the population with very high risk to lowering the cutoffs for what is considered sick. That's true for hypertension and hyperlipidemia, but also for a wide range of other risk factors and diseases. So we end up wanting to prevent disease for a very large proportion of the low risk population. And that's done by drugs, so medicines to lower risk factors. But it's also done through this idea that we as clinicians should try to change the lifestyle of our patients. And that's a very intuitively appealing idea because a lot of the problems with health and well-being today are related to lifestyle factors. But just because it's good to lose weight for health outcomes, it doesn't mean that us giving people advice to lose weight is good, because it might not help them change. It might not help them change their behavior. And in fact, when you look at the totality of the evidence, it seems that in the absolute majority of cases, our lifestyle advice have a very small benefit, very low likelihood to actually help people change behavior. And yet it's massively introduced in a mass scale. So the evidence to support it, that it actually has any benefit, is very weak. And it has massive opportunity costs, because the time that I would spend on giving my patients lifestyle advice would take away all time to discuss, suicidal thoughts or a pain in the knee or anything else that matters to the patient. So yeah, that's my conclusion. And I also want to say that I'm not saying that we should never talk about lifestyle with a patient, but we should be very humble to the fact that our advice rarely helps people change behavior, that it might have harms like stigmatization, etc., and that it has opportunity costs, that if we spend a lot of time on it, that will reduce our time for something else, and that might not be worth it. Can I say just one more thing here? My interest in this lifestyle intervention topic started when I met a patient that I had known for a couple of years, and she came for pain in her body, and she had obesity, and I thought that I brought up her weight in a very respectful way, but she said something like, doctor, I've been struggling with self-hate, body hate, and eating disorders my whole life. I have finally accepted that I'm fat, and I would like to be able to go to the doctor just for once without having my weight pushed up in my face. And I learned so much from that. We had a very good discussion afterwards, which I thought was really helpful for me to understand this. Yeah.
That was an incredibly powerful consultation, wasn't it?
Yes, it was. It was, and I felt terrible at first. It felt like a horse pushed in on my chest, But then, as I said, I learned a lot, and it gave a lot of reflection, and our relationship grew from that. And she's still my patient, and she has also agreed that I can share this story. So.
Well, this brings us on to some of your most recent work, which talks about the false promise of prevention.
Yeah, I wrote a paper together with also some brilliant colleagues, Iona Heath and Stephen Martin and Richard Lehmann and Tina Korovnik, which was published in the BMJ, in which we argue that this expansion of individualized prevention within healthcare that has happened in the last decades, that that it takes so much time and effort that we don't have enough time to spend on the people who are ill. So it's a distortion of general practice. We sacrifice patient care for people who are ill for prevention of low-risk populations, which does not have strong scientific evidence that it's actually helpful, and a very slim benefit at best.
I mean, you're doing this 27-hour day, you're writing all these papers, you're an academic, you're running this global center, have a number of PhD students. Where do you find time to relax yourself?
Well, I am a little bit of a workaholic. I love working. I think it's very rewarding and fun, but I'm also very good, I think, at just compartmentalizing. Like when I come home to my kids, it just shuts off and it's full focus on them. And I think it's very important to always know what you prioritize. Like my kids and my family is my highest prioritization. And if they need me, then everything else is just secondary. I think it's very important to just make that mind up and just follow that through everything. So I think my family helps me relax and and enjoy other stuff in life than just work.
That's a lovely note to end on, Minna. Thank you very much for sharing so much of your life, your career, and your philosophy. It's been wonderful chatting to you. Thank you very much indeed.